I'm going to get started, and I'm Gwen White. I have the privilege of being one of the co-leads of the effort at the Southwest Mental Health Technology Training Center to support your work with youth and young adults of transition age. So this is a disclaimer that anything said during the webinar are not necessarily the opinions of our funders at SAMHSA or of HHS. A little bit about the Pacific Southwest Mental Health Technology Transfer Center. It serves the mental health workforce in Region 9, which you can see in that little magnifying glass, is Arizona, California, Hawaii, Nevada, and the Pacific Islands, America, Samoa, Guam, the Marshall Islands, the Federated States of Micronesia, Northern Mariana Islands, and Proulx. So welcome, all of you. The role of Region 9 is to offer a collaborative model to provide training, technical assistance, and resource dissemination for the work you do, and that includes what you're listening to now, the information pertaining to young adult services and support. And the goal is to promote the strategies that support you as stakeholders in your role. And hopefully we can see a lot of that in the chat box. This slide illustrates the services that are available through the TTC. We're glad you joined us today for our webinar, and please avail yourselves of opportunities as you see related here. So, a little bit about today's team. As I told you earlier, I'm Gwen White. I'm facilitating today's call. Kristin Thorp and I co-lead the efforts around youth and young adults for the center and nationally. Kristin will be presenting today along with Lydia. It's a privilege for me to work with both of them. You will enjoy learning from them too, and they will be introducing themselves.
All right. Hi, everyone. This is Kristin Thorp. I'm a project coordinator for Youth Move National. I've been with Youth Move National for several years and kind of a bit of a jack of all trades. And as Gwen mentioned, I've been doing the co-lead on this, presented a couple of other webinars, and looking forward to talking about mental health equity today.
Hi, my name is Lydia Proulx. I'm a youth program specialist at Youth Move National. I've been in National a couple of years. Prior to that, I was the youth program manager of Youth Move Massachusetts, which is how we and our family run your organization here. I'm very happy to be visiting with you all today. Thanks for having me.
So this is Kristin again. So today's objectives are to understand the link between health disparities and mental health equity, gain knowledge about the unique mental health equity challenges facing youth of transition age, and learn about practical strategies for advancing mental health equity for youth and young adults. So adolescents ages 10 to 17 and young adults ages 18 to 25 make up 22% of the United States population. The behavioral patterns established during these developmental periods help determine young people's current health status and their risk for developing chronic diseases during adulthood. 1 in 5 youth in the United States has a diagnosable mental health condition. Unfortunately, access to care for youth and young adults is poor. At least 85% of those in need of treatment do not get it, and more than half of mental illness emerges before age 14 and 75% before the age of 24. So getting youth and young adults the help that they need, in addition to ameliorating their immediate suffering, can really prevent future pain as well. The results of not getting help can be dire, as suicide is now the second leading cause of death for those between ages 10 and 34. Mental illness exacts a staggering cost on society. It leads most measures of economic burden for non-communicable diseases. The World Economic Forum issued a report that mental illness has a greater impact on economic output than cancer, heart disease, or diabetes. The report's authors estimate that the worldwide cost of mental illness is to be $16 trillion between 2011 and 2030, and other recent research has indicated that untreated anxiety and depression cost society $1.15 trillion annually. However, in the United States, the expenditure on mental health as a percent of total health budgets is grossly inadequate given the prevalence of mental illness. Although adolescence and young adulthood are generally healthy times of life, Some important health and social problems either start or peak during these years. Because they are in developmental transition, youth and young adults are particularly sensitive to the influences from their social environment. Their families, peer groups, schools, and neighborhoods can either support or threaten young people's health and well-being. Societal policies and cues, such as structural racism and media messages, can also do the same. Older adolescents and young adults, including those with chronic health conditions, may face challenges as they transition from the child to the adult healthcare system, such as changes in their insurance coverage or legal status and decreased attention to their developmental and behavioral health needs. Bolstering the positive development of young people facilitates their adoption of healthy behaviors and helps ensure a healthy and productive adult population. Adolescence is a critical transitional period that includes the biological changes of puberty and developmental tasks such as normative exploration and learning to be independent. Young adults who have reached the age of so-called adulthood also face significant social and economic challenges with few organizational supports at a time when they are expected to take on adult responsibilities and obligations. And it's also important to note that there are significant disparities in outcomes among racial and ethnic groups. In general, youth and young adults who are African American, American Indian, or Latinx, especially those living in poverty, experience worse outcomes in a variety of areas compared to youth and young adults who are Caucasian or Asian American. And in addition, sexual minority youth have a higher prevalence of many health risk behaviors. Before we get into the conversation about health equity, it's important to understand some of the underlying things that can affect health equity. Social determinants of health are defined by the World Health Organization as the circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces: economic, social policies, and politics. There is no health without mental health, and in part, our health is determined by access to social and economic opportunities, the resources and supports available in our homes, neighborhoods, and communities, the quality of our schooling, the safety of our workplaces, the cleanliness of our water, food, and air, and the nature of our social interactions and relationships. The conditions in which we live explain why, in part, some people are healthier than others and why Americans, more generally, are not as healthy as they could be compared to nations of similar wealth and development. All young people deserve an equal opportunity to make the choices that lead to good health. But to ensure that all youth and young adults have that opportunity, advances are needed not only in the field of mental health and healthcare, but also in areas such as education, childcare, housing, media, community planning, and transportation. And just some examples of social determinants include availability of resources to meet daily needs, so for example, safe housing and local food markets, access to educational, economic, and job opportunities, access to healthcare services, transportation options, public safety, and then example of physical determinants include their natural environment, so such as green space or weather, the built environment, which is really important, such as buildings, sidewalks, bike lanes, or roads, housing and community design, exposure to toxic substances and other physical hazards, and physical barriers, especially for those living with disabilities. And by working to establish policies that positively influence behavior, we can improve health for large numbers of young people in ways that can be sustained over time, improving the conditions in which we live, learn, work, and play, and the quality of our relationships will create a healthier population, society, and workforce. I'm going to hand it over to Lydia to talk a little bit about some social determinants of health for LGBT people.
Thanks so much, Kristin. So many of the examples I'll use when illustrating what Kristin's talking about or illustrating my experience and the work that I'm in is going to referencing LGBTQ2F youth. Youth Move National is a core partner in the Quality Improvement Center, or QUIC, LGBTQ2F, and so which is working to improve foster care and permanency for LGBTQ youth in care. And so much of the information and sort of what I've been working through lately and what's very relevant is included in this presentation for you. So some of the examples of what might be social determinants of health for LGBT folks include legal discrimination. So legal discrimination in accessing health insurance or how health insurance benefits are distributed, access allowed, employment stability, housing, adoption rules, retirement benefits. There's a lack of laws protecting against bullying in schools. Many states may have certain protections against bullying, against sexual orientation, for example, but not cover gender identity. There aren't comprehensive laws across the board for students in schools. Access to knowledge and competent healthcare providers, very difficult in some locations or for some young people to access accurate information and to have knowledgeable, safe adults to go to, or even begin to know where to find that information. Access to safe schools, schools being a challenging environment for LGBTQ youth, housing, recreational facilities, activities. All of these things may include things such as using the restroom. You wouldn't use the restroom at school, in your home, if you're at the YMCA or other recreational places, different activities. Elderly LGBTQ people face additional barriers in health because of isolation and a lack of culturally competent providers, particularly just in training. Folks who work with elderly populations are often, it's not considered, sexuality and gender orientation is something that's not often considered. And so there's a lack of these culturally competent skills in that workforce. So we know that social determinants of LGBTQ folks will impact their health. LGBTQ youth are 2 to 3 times more likely to attempt suicide. LGBTQ youth make up 40% of the homeless youth population, like being something like 10% of the general population. They have the highest rates of tobacco, alcohol, and other substance use in their peer groups. And transgender folks in particular are at a higher risk for STDs, victimization, mental health issues, and suicide. And they're less likely to have health insurance than their heterosexual or LGB peers. This is important, especially when we consider alongside race, ethnicity, disability. The greater the marginalization and disparities a person faces, the more impact that may have on their health outcomes. So, for example, gay men of color have higher rates of STDs than white gay men. And we know this can be challenging once you start stacking all of their personal identities and also system involvement and all these different pieces on top of a young person's identity, what their social determinants and how their health may be.
Thank you, Lydia. So the Robert Wood Johnson Foundation defines health equity as meaning that everyone has a fair and just opportunity to be as healthy as possible. And this requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. Health and mental health disparities are the differences in health and mental health status among distinct segments of the population, including differences that occur by gender, age, race or ethnicity, sexual orientation, gender identity, education or income, disability or functional impairment, geographic location, or any of combination of those factors. Although the term disparities is often interpreted to mean racial or ethnic disparities, key dimensions of disparity exist in the United States, particularly in health. If a health outcome is seen to a greater or lesser extent between populations, there is a disparity. Race or ethnicity, sexual identity, disability, the socioeconomic status, and all of those things that I mentioned just a bit ago all contribute to an individual's ability to achieve good health. It's important to recognize the impact that social determinants have on health outcomes of specific populations. Across the nation, gaps in health are large, persistent, and increasing. Health equity means everyone has a fair and just opportunity to be healthier. It acknowledges that it's hard to be healthy without access to good jobs, homes, and schools. And health inequities are rooted in social injustices that make some population groups more vulnerable to poor health than other groups. It requires concerted effort to increase opportunities to be healthier for everyone, especially those whose obstacles are greatest. For example, Margarita Alegria and colleagues reported that those who had depressive disorder in the previous year, who had depressive order, more African Americans, 59%, Latinos, 64%, and Asians, 69%, received no mental health treatment for depression compared with non-Latino whites, 40%. And another research study found that nearly a quarter of white women, 23%, with a mental health challenge received treatment as opposed to only 9% of African American women. So achieving health equity really requires valuing everyone equally with focus and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Health equity and health disparities are intimately related to each other because health equity is the ethical and human rights principle that motivates us to eliminate health disparities, which are, again, the differences in health or its key determinants. And I'm sure many of you have seen some version of this graphic before, but I just really like how this one really demonstrates what achieving health equity looks like in terms of personalizing our response and being responsive to the needs of different populations. So why don't young people actually get the care that they need? So the World Health Organization outlines 3 primary components of access to health care: physical accessibility, financial affordability, and accessibility. Physical accessibility involves providers' geographic proximity and availability at convenient times for youth and young adults. It's also important to consider the physical space and location in the context of the general built environment. Is the area safe? Will youth feel comfortable going? Is it within walking distance of a public transportation or other community-based services that youth might already be accessing? These considerations make a big difference in whether or not a young person will engage in services. Affordability means that those who want health care can get it without financial hardship. And acceptability means that young people believe that their care is responsive and respectful of their social and cultural background. While access issues affect youth and adults alike, youth and young adults frequently come up against more barriers across all of the primary components of access to care, including a lack of youth and young adult specific services, a lack of knowledge about what resources and services are available in their communities, a lack of continuity of care between the child and adult systems, and their own patterns of health-seeking behavior. Many youth that we are engaging with are pretty system weary, so they might have an absence of trust in the system. And young people also just have a tendency to seek informal support, such as reaching out to friends or families or other significant adults over the more formal sources like a therapist or family doctor. Socioeconomic status, so income, along with education, has a really striking association with health. Research has shown that U.S. adults living in poverty are more than 5 times as likely to report being in fair or poor health as adults with incomes at least 4 times the federal poverty level. That income is important to health. It might not be surprising to most of you all, but the magnitude of the relationship is not always appreciated. One research article I read estimated that living on incomes of less than 200% of the federal poverty level claimed more than 400 million quality-adjusted life years between the years of 1997 and 2002, meaning that poverty had a larger effect than tobacco use or obesity. Excluded or marginalized groups are those who have suffered discrimination or have been excluded or marginalized from society and the health-promoting resources it has to offer. They've often been pushed to society's margins with inadequate access to key opportunities. Because of that, the places where they are able to live often have health-damaging or non-health promoting conditions such as pollution, lack of access to jobs and services, inadequate schools, all of which contribute to a young person's mental health. In low socioeconomic status conditions, youth experience more stressors and again are less able to counteract that stress. Of course, adverse childhood experiences, or ACEs, also have a lasting impact on a youth's mental and physical development. Studies of social stresses and its consequence for mental health frequently evaluate childhood and lifetime traumas as well as chronic enduring conditions. This is illustrated by results showing that a single stressor or no stressor at all produce a 1% increment in psychiatric disorders in children, while 2 stressors in the family complex provide a 5% rise in the disorder rate, 3 stressors a 6% increment, and 4 or more stressors jump to a 21% increment in the rate of childhood psychiatric disorders. Cumulatively, the presence of stressors accounted for 33% rise in the disorder rate, with multiple stressors accounting for the largest proportion of the disorders. Family-level factors can also create barriers in access to mental health services, particularly for minority youth. Mental illness stigma remains high in minority communities, possibly due to the fear of the double stigma of being both a member of a marginalized racial or ethnic group and a person who is perceived to have a mental illness. For youth who are still dependent on caregivers to initiate and coordinate mental health services, access to care may be blocked by a parent or caregiver who disapproves of mental health care, even when other structural barriers may not be present. Additional barriers can also include lack of citizenship of a family member, or even many of us work with undocumented youth as well, shortage of mental health providers in the area, a parental lack of recognition of psychiatric symptoms, different preferences, and of course different expectations of care. And further, adversities are more likely to occur in a single parent household rather than in a 2-parent household. Consistent evidence shows that socio-ecological context is an important predictor of the prevalence and differential course of mental illness also. Understanding the contribution of neighborhood context as a mechanism for explaining disparities in mental health outcomes is particularly critical. Disparities can often be seen as resulting in part from cumulative adversity, so due to factors that disproportionately affect minorities, including childhood and generational trauma, things like stress or poor housing, or cultural hardship, so discrimination, prejudice, stereotyping, a general sense of not belonging, that over the long term really cause poor health and mental health outcomes. Distressed homes and neighborhoods can induce disease and contribute to disparities via pathways unrelated to behavior. For example, housing can expose occupants to lead and allergens. Bus depots, factories, highways, and hazardous waste sites are often situated near low-income and minority neighborhoods. Distressed communities have a notorious shortage of healthcare providers, especially in primary care, which is often the first line of defense with mental health challenges. And social conditions are, they're important. Health may be compromised by the chronic stress of living amid multiple adverse conditions. And these neighborhoods may also have reduced social cohesion, which can influence health behaviors. So the sense of security and social well-being experienced by members of the community, and the ability of individuals within a community to join forces and advocate for needed services. So for example, minority neighborhoods with poor social cohesion may be unable to mount effective political decisions that might affect, for example, local schools. Historically, the United States' long eras of slavery and discriminatory policies in housing, education, transportation, and economic development largely excluded people of color and other minorities from the formal economy up until the latter half of the 20th century and the passage of major civil rights legislation. Although many of these policies, such as lending institution redlining, have been prohibited by law in recent decades, their harmful legacies persist in numerous less obvious ways, both officially and unofficially. So for instance, it's widely recognized today that private and public bank lending policies that enabled the subprime mortgage practices during the housing boom contributed significantly to the 2007 to 2009 housing bust, which wiped out vast shares of homeowners' household wealth. The bust affected all but the richest few percent of the population and having a much greater negative impact on low-income households, especially communities of color. Public policies and private practices affecting the economy, housing, the environment, education, and other sectors are a major factor in the persistence and growth of the widening American wealth gap, which is a key driver of health inequities among low-income families, communities of color, women, youth, and other vulnerable populations. Fortunately, policies are not carved in stone, and they can be reshaped to address inequities and promote greater access for all people. And of course, racism can affect disparities in multiple ways. Racial differences in socioeconomic status, again, one of the strongest predictors of variations in health, partly reflect the impact of economic discrimination produced by large-scale societal structures. Racial segregation determines access to educational and employment opportunities, and importantly, constrains socioeconomic mobility of people of color. There are racial differences in the quality of education, income returns for a given level of education or occupational status, wealth or assets associated with a given level of income, as well as stability of employment and health risks associated with occupational status. The health of racial and ethnic minorities can also be influenced by large-scale policy change, for example, welfare reform or cuts to the SNAP program, or the states that chose not to expand Medicaid. So exposing youth and young adults to today's adverse social conditions has ramifications for the health of tomorrow's adults. It has already been predicted that this generation could, for the first time in U.S. history, live shorter lives than its predecessors. Children's exposure to worsening socioeconomic conditions from fetal life through adolescence could alter the trajectory of their health, making them more likely to develop disease later in life. These outcomes could intensify demands on a healthcare system that is already too costly to sustain. And access to quality mental health care impacts, again, one's overall physical, social, and mental health status and quality of life. There are many consequences of health disparities, including unmet mental and physical health needs, delays in receiving appropriate care that could lead to increased complications or emotional distress, preventable hospitalizations and out-of-home placements, and financial burden both at the micro and macro level. There's also a cost to society as a whole, not only in terms of economic expenditures, but in the losses of productivity and a young person's ability to achieve their full potential. And I'm going to hand it back over to Lydia to give some examples of what this looks like.
So we do know that there's been a huge rise, for example, in Uber and Lyft usage rather than ambulances to get to the ER. Folks know that they cannot afford the ambulance bill and will use a rideshare service. So much so that these rideshare services now have policies around how their drivers respond to requests to go to the ER and how they should react to those. We know that Black women are 3 to 4 times more likely to die in childbirth than white women. Since 1990, maternal deaths have been rising in the United States, which is a significant departure from the world's other richer countries. By 2013, rates have more than doubled. And the CDC now estimates that 700 to 900 new and expectant mothers die in the United States each year. And then an additional 500,000 women experience life-threatening postpartum complications. More than half of these deaths and near deaths are from preventable causes, and a very large proportionate number of those women suffering are Black. There have been multiple reports that childbirth and pregnancy are a very risky series of medical procedures for Black women, when for white women they're not considered nearly as high risk. According to the World Health Organization, Black women's odds of surviving childbirth in the United States are comparable to those of women in countries such as Mexico and Uzbekistan, where significant portions of the population live in poverty. So again, we see this poverty piece coming up about how that affects health outcomes. We know that Native American and Alaskan Native children are 3 times more likely to be removed from their home than white children are. Former foster youth appear to have a higher risk of multiple chronic health conditions beyond that which is associated with economic insecurity. So even beyond the poverty piece, this foster care layer adds another layer of chronic health conditions and poor outcomes. Youth in foster care experience poor mental health and physical health relative to the general youth population, and this is across family types of single, 2-parent households, and economic status. So we're going to talk about how we're advancing mental health equity. The first thing I wanted to talk about is utilizing a youth-driven approach. So using a youth-driven approach when you're advancing mental health equity for young adults of transition age really changes institutional culture and practice. There's a real shift in how an organization or agency, how a service delivery process feels. It can help design and implement new policies that better serve youth and young adults. One way I ask people to think about this is when anyone designs a product. Research and development teams, they don't often design a product and then just put it out there and see how it goes. They have a ton of focus groups. They have market research companies working for them. There are surveys. They're tracking, what we're all buying on Amazon and things like that to see what the public wants. So same idea. If we're asking young people to help us design these policies and help us provide services, they'll be new and better. Youth-driven approach builds awareness and understanding within the organization or within folks who are designing policy of what a young person's experience in a particular system or the particular disparity really is. Build self-efficacy. On the other side, we're seeing young people who are involved in youth-driven approaches change. They become more effective self-advocates. They become stronger individuals and then possibly go on to work in these fields themselves. Build a sense of community, people working together. And then provide improved individual and organizational outcomes. So it will improve, obviously, that young person if they're choosing to engage and they're learning these new skills and they're sort of involved in the design and implementation of new policies, they will grow as an individual, but also the organization benefits this involvement of young people. Youth engagement activities. This is from a sheet that the TA Network has put out around family and youth involvement in residential treatment, but it's a really great place to look at possible activities that if you are working on policy or you are working in your agency, how young people could inform, consult, get involved, be collaborators, and be empowered in your work or your agency. So from informing projects, they might give feedback on the website. Say, this looks really good. They might help staff kiosk or information booths. They could be feature stories. So sharing their stories, sharing their experience, and using that YouTube video in trainings or using that YouTube video or that written testimony. It might be at fairs and events. If young people are consulting on a project, they might be in that focus group, right? That research and development piece. They might be taking the surveys or even designing the surveys and helping ask, think about what questions do you want to ask? This is what we want to learn. All this through involvement where they're serving as expert panelists, they're facilitating the groups, they're starting to take more of a lead. They're serving on advisory groups where there's an ongoing mechanism for how they're going to offer feedback and be involved in that design and policy process. And then eventually they are empowered decision makers as part of your team and part of policy making. They're hired staff, they're leaders in the youth and family movement. So this is a great chart if you are wondering about what that might look like. We can say youth-driven approach all we want, but how it actually looks like on the ground is going to be a little bit different. And these are some good places to start.
So why do we as behavioral health providers need to be concerned about social determinants of health? As we've discussed throughout this entire webinar today, mental health and many common mental health challenges are shaped to a great extent by the social, economic, and physical environments in which people live. So as behavioral health providers, we're striving to, provide the highest level of care to the individuals and the communities that rely on us. So it's important that we're as current as possible with our knowledge of the field. The current trend in our training focuses on the genetic and behavioral components of mental illness. And this focus really has us prioritizing things like medication management or behavioral components like individual behavioral change through something like CBT. But what if we considered that medical care and healthy behaviors and genes and biology altogether account for only about half of society's overall health outcomes? Then we can really begin looking seriously at the environmental and social conditions that play an outsized role in the mental health and well-being of those in our care. So when a society's principles and policies work to optimize these interrelated social determinants of health on the basis of justice and equity for everyone, health is created at the individual level, the community, the environment, and then society at large. So when any combination of these drivers is lacking, the engine that powers total health can break down, resulting in significant health inequities and disparities in health outcomes. So understanding what creates or limits the opportunities for health is essential to understanding what creates disparate health outcomes and what needs to be done to prevent them. So this graphic is really nice in showing kind of the different levels of achieving a healthy society and some of the things that can impact those inequities that we see. So what are some things that we can do to address and advance mental health equity? Lydia just shared with us the example of a youth-driven approach, which is always a really good starting place, especially when you are working with young adults of transition age who are seeking to become more empowered. The one big thing that I consistently see is the adopting a health in all policies approach. The American Public Health Association describes health in all policies as a collaborative approach to improving the health of all people by incorporating health considerations into decision-making across sectors and policy areas. Health in all policies is really based on the recognition that the greatest health challenges, including the health inequities described throughout this webinar, are highly complex and often interrelated. Health in all policies builds on a public health long and successful tradition of collaboration among government sectors as well as private agencies. And because public health and healthcare institutions do not have authority over many of the policy and program areas that impact health, so for example, transportation policy, solutions to these complex and urgent problems require working collaboratively across many sectors to address the social determinants of health, again, such as transportation, housing, or economic policy. Another health equity strategy requires a supporting organizational structure that can manage your health equity work and efforts. Because many health equity related elements need to be considered in the strategy. So for example, in things like hiring or internal staff training and the care redesign, you will need to establish some kind of oversight committee perhaps to enable people throughout the organization to work together on shared health equity goals. And this will require dedicating resources, both in time and actual fiscal resources, to your health equity efforts. And to improve health equity, organizations first need to understand where disparities exist. So this requires accurate collection of race, ethnicity, and language data, along with the resources to analyze it. Achieving health equity requires societal action to remove obstacles to health and increase opportunities to be healthier for everyone. So it's crucial to document inequities and disparities to motivate and inform your efforts to eliminate them. Without measurement, there's really no accountability for the effects of the policies or programs that are being established. Healthcare organizations must understand ways in which they contribute to structural or institutional racism. So institutional racism is not the bigotry that many people think of when they hear the term racism. Samara Jones, the research director on social determinants of health and equity from the CDC, explains, institutionalized racism is defined as differential access to the goods, services, and opportunities of society by race. Institutionalized racism is normative, sometimes legalized, and often manifests as inherited disadvantage. It is structural, having been codified in our institutions of custom, practice, and law, so there need not be an identifiable perpetrator. So in trying to better understand institutional racism, we describe the structures, norms, rules, regulations, and policies that mental health care organizations have control over that might contribute to health disparities. It's also important to identify and address not only overt discrimination, but also unconscious and implicit bias and the discriminatory effects, whether or not they're intended. Implicit bias, also known as unconscious bias, is the bias in judgment and or behavior that results from subtle cognitive processes. So, for example, our implicit stereotypes that we have. And they operate at a level below conscious awareness and without any intentional control. So it's not malicious intent. It's just things that we've internalized as we've been in our work or in our lives. So one strategy that I know I've done in work previously is, kind of to better understand even my own implicit bias is just to take the Harvard implicit bias test, which is available if you just do a quick Google search. And the ability of health and mental health care providers to effectively communicate with recipients and to understand and respond to their cultural beliefs and values regarding health and illness and wellness is essential for providing high quality care to every person and as well for reducing health disparity among social groups. So in addition to hiring diverse staff, it's also essential to receive training on providing culturally responsive care. In Lydia's example earlier, Youth Move National has been working on a project on developing interventions to improve permanency for LGBTQ2S youth in the foster care system. And of course, expanding access to care is a key strategy for advancing mental health equity. When and where possible, agencies should adopt and implement services that support youth and young adults of transition age. So for example, something as simple as adopting a flexible scheduling practices, having like a couple hour window when youth can pop in and don't have to have an appointment. Or perhaps eliminating kind of punitive no-show 3-strike policies, which I know a lot of youth I've worked with struggled with. And of course, build on the existing strengths and assets, not only of your organization, but also the youth that you're working with. And of course, increasing prevention efforts. Prevention in health is a really broad concept. It can occur in healthcare in a range of settings and in various ways, including public health strategies to prevent the occurrence of disease. So, for example, things like anti-smoking campaigns, clinical strategies or treatment detect early stages of a disease. So that brings to mind things like first episode psychosis training or clinical interventions to really prevent complications of an existing disease. Prevention also includes public health activities such as health education about risky or positive personal behavior and changes to the larger environmental or social conditions that have an impact on health. In all these ways, prevention has long been recognized as an essential public health strategy for creating better health and promoting health and mental health equity throughout society. And increasing prevention is really considered a very low barrier approach to addressing inequities. And reducing the effects of childhood adversities, such as exposures to abuse, family or community violence, and drug use, requires intervention at both family and community levels. So one approach to preventing childhood adversities is the implementation of things like parent training programs, which teach parents maybe effective parenting techniques. And they can be tailored to parents of children with mental or behavioral health problems or to parents who are experiencing their own substance abuse or mental health challenges. And these programs really can reduce child abuse and exposure to other potential traumas by promoting nonviolent strategies for improving child behavior and dealing with anger, as well as strategies to limit child exposure to parental or community drug use and neighborhood violence. One thing that you all can do is, tap into your existing youth and family organization. It can be a really great way to build community partnerships to really promote protective factors for youth and young adults. And this, of course, goes hand in hand with adopting trauma-informed care. And integrating mental and physical health is another mechanism for addressing inequities and mental health. This strategy serves as a response to the growing need to address mental and physical health needs in primary care settings, where most low-income minorities tend to first seek help for emotional problems. And then finally, evaluate and monitor your efforts using short and long-term measures, as it may take decades or even generations to reduce some of the health disparities that we see. In order to not underestimate the size of the gap between advantaged and disadvantaged groups shouldn't be compared to the general population, but rather to advantaged groups. And tailor your quality improvement efforts to meet the needs of marginalized populations. Quality improvements can sometimes unintentionally actually worsen health disparities for some subpopulations. For example, when quality improves for one racial group, and it's often the group who's already doing a little bit better, at a faster rate than others, again, often the groups that are doing worse, quality for the whole population improves, but the gap between this population widens. So focusing on the whole population rate obscures the fact that the disparities for some subpopulations are actually worse than before. And so for the health equity movement, the challenge really is to clarify the connection for policymakers that we can't focus exclusively on how physicians or therapists can reduce disparities, but rather that equitable healthcare is essential, but health disparities will persist as they have for generations until attention really turns to kind of these root causes that are outside the clinical experience. And with that, I think it is time for questions.
It is, and I'm responding to, I think it's Ruth, Samantha got in there. There's lots of activity in it's Elizabeth, who says they've been shifting the language from resilience-based care versus trauma-informed. Are you aware of that, either Kristin or Lydia?
I have definitely heard that language. I mean, I think still at SAMHSA that the default is trauma-informed care, but I have definitely heard that term, and I think it's a really nice way of framing it, much more, strength-based.
Mm-hmm. Thank you, Elizabeth, very much for pointing that out. Several people have used the Harvard implicit bias scale survey, and I have appreciated that. So thank you for bringing that up, Kristin.
I mentioned, Gwen, is the Institute of Healthcare Improvement has a document that they created that has a really nice, almost like a self-assessment, like an organizational self-assessment. And it says healthcare organizations, but I think it's very applicable in the mental health field as well, kind of to help organizations evaluate what their current focus is on health equity and improvement efforts, and related to kind of their framework in terms of, making it a strategic priority and developing structures and that sort of thing. So I'm happy to share that as well, because I think sometimes it can be a kind of nebulous. We know in theory what sounds good, but then putting it into practice can be really challenging. So I'm happy to share assessment tools and things like that if people are interested.
That's the Institute for Healthcare. What is it?
It's the Institute for Healthcare Improvement, the IHI.
I have for a long time, Kristin, thought and looked into this idea of what I call multiple jeopardy with young adults. They're at risk because of their age, their mental health, multiple system involvement, being part of minority populations, just sort of keeps adding on and on and on. So now I have to add health inequities. So I appreciated that. It's not the good news, certainly, but it's an addition to that idea of multiple jeopardy.
Yeah, the research that I was doing specific to kind of, Lydia, do you have any? I'm thinking of, there's been a lot of work with again, it's not mental health specific, but it kind of overlaps because system involvement does often overlap. So for example, the Robert Wood Johnson Foundation does a lot of health equity work, and we actually partner with them to do kind of a mental health equity award for a young adult advocate. And actually, if you want to nominate anyone, that's currently happening. And there's a $3,000 unrestricted cash prize. But Robert Wood Johnson Foundation does a lot of mental health equity work. They're always a great resource. And for example, they do the JDAI, the Juvenile Detention to Alternatives Initiative, with youth in juvenile facilities. And I know that they very actively involve young people throughout that process. Young adults who have previous systems experience go in and do, kind of an assessment of the facility, and then help write reports on what are recommendations for improving conditions and including equity. So, the Robert Wood Johnson Foundation reports for JDAI almost always have a section on how to work with transgender youth in their facilities, because we know that that's a really challenging issue on both sides of the coin, so they're very good about including information or suggestions that are very equity related. And although it's not mental health system, it is a framework for how you can engage young people, as Lydia mentioned, involving young people in focus groups or involving young people in your quality improvement teams. That's a really, it's not easy. Actually, it takes a lot of resources and time and preparation and debriefing, but it's one strategy, involving young people. Young people are often best equipped to identify what's not working and what might work better.
Two examples I can think of are both in Massachusetts, which I know is cheating. I'm sure I could tap our coworkers and get a few more from our networks. But in Massachusetts, Youth Move Massachusetts has worked within juvenile justice in particular on policies that would allow siblings to visit their siblings who are in detention or in DYS custody. Thus, when that young person transitions back into the community at age 18, or when they do transition back they had a stronger family support network. Multiple youth movement members had not had sibling connection. And then when they came out, their siblings didn't know them. And so that was a big project and push policy-wise. Again, that was done in conjunction with JBAI in Massachusetts. Another group outside Boston, Everett Teens Educating About Substance Abuse. They had a peer-to-peer anti-tobacco and substance use support and campaigns, including working with police to develop better community connections and relationships with youth in different communities. Everett, Lynn, and Revere are cities outside Boston that are, I don't know if they're majority of color, but they have a lot of immigrant and a lot of youth of color who are disproportionately affected by police intervention and different things like that. So there are a lot of examples, and I'm sure we could share some more. And if you want to get in touch with those groups, speak with them directly, that may be an option too.
Thank you, Kristin and Lydia. And then Denise was wondering about filing legal claims. I'm certainly not aware, but young adults or their families or those having some help to filing legal claims in terms of insurance companies.
When I worked with the Parent Professional Advocacy League and Youth Move Massachusetts, part of my job was supporting young adults to access things such as like fuel assistance, food assistance or SNAP or food stamps, as well as mass health. And that did involve filing appeals. Sometimes they were successful and sometimes they were not. I think the one, I hesitate to say universal because saying all is kind of a, but many of the young adults I supported through that process felt very exhausted by having to appeal. Very much the sense of like, this system should work for me the first time. And so I think that when we talk about system weary, that, if you're applying for food stamps and then heat assistance and then you need to figure out a therapist who's currently taking your insurance, but they won't cover more than such and such a number of sessions, that adds up very quickly, the amount of communication. It's a part-time job keeping up with that. So I think the systems theory piece comes into that. And I would not be surprised if different pieces such as poverty level or race and ethnicity, disability came into play as well to affect the ability of folks to access insurance.
And Denise says that in Arizona, they are having some success with that. Thank you, Lydia, for putting that there.
The parity law is very important and very hard sometimes to explain to folks on the ground when you're, walking into a mental health facility or something like that and understanding that folks have a certain set of rights and a certain expectation, and then sometimes the application doesn't trickle all the way down. It can be very challenging.
Mm-hmm. Mm-hmm. One thing I've thought about is I spent a lot of time working with change initiatives around the transition to adulthood for young adults with mental health concerns. We all do. And we've always talked about those transitions many times. We've talked about those transitions from child serving systems to adult serving systems only. But this is a big reminder that healthcare transitions are really important too. And given all the factors you both identified that can hamper that, there's also the things that young adults have a very hard time when they leave pediatric care, finding an adult healthcare provider that they're comfortable with or they have easy access to. Any thoughts on that?
I would agree. I mean, in my own personal experience, that was a challenge, and I think many young people I've talked to and worked with, that's been a challenge. I think much like moving from a child-serving mental health system to the adult system, there's two different cultures there, right? There's two different ways of approaching health or approaching care. And I think, in pediatrics, they're very developmental focused and very sort of wellness, whole health kind of focused, environment focused, involving the family. And then you move to an adult, you turn 18 and there are all these releases so that can they talk to your parents. And there's a different way that internal medicine doctors are trained to approach health, more of this is an illness, let's fix this one thing that's wrong, rather than kind of a whole developmental approach. And so I think there's a difference, just no one really prepares you for how you want to advocate in your adult doctor's office, or what language might be effective with that doctor versus what was working with your pediatrician. What kind of assumptions would both of those two different types of doctors have? So I've seen that and certainly experienced in my own life. I don't know, Kristin, if you have anything to add about primary care?
So I think I mean, as I mentioned, and also this has been my own experience with my own mental health care, is that your primary care physician often is your first line of defense before, or if you have, depending on your insurance, if you have an HMO, you might, depending on the rules of that particular HMO, you might need to get a referral to be allowed to go to a psychiatrist.
Mm-hmm.
Yes, I think that all of those things can become barriers. And again, like as Lydia mentioned, like that system weariness, it's like it just gets kind of, all of those things add up and you just kind of shrug your shoulders and say, forget about it. And that's when you stop seeing engagement. That's why it's so important to have things like youth-driven care embedded into your practices and really do things like work partnering and collaboratively creating a health plan that's going to work for everyone. Being flexible in terms of if people want to try maybe alternative, I think again with primary care doctors, like often the first line of defense is like, let's get medications, but maybe a young person would like to try something alternative. And being willing to be flexible to hear a young person out and maybe say, let's try this, do almost like a miniature PDSA and like, let's try it for 2 months and see how you're feeling. If it's not working, then we can go this other route. And so I think that there's lots of little things like that that can make a young person feel heard and make a young person feel like they are in charge of their own healthcare. That can make a big difference in retaining them in their treatment.
Thank you, Kristin. Kit just posted a huge question. We could probably have another webinar on it. What would you, from your research and your personal experience, encourage practitioners in terms of building rapport with youth and young adults? I think that there are a lot of veteran and very seasoned practitioners, but sometimes they have trouble clicking with a younger population.
Mm-hmm. I mean, I think what I just mentioned about, kind of collaborating and being willing to hear a young person out or ask a young person what their preferences are before making assumptions. I mean, I think those are really small gestures that go a long way in making a person feel that they're heard. Lydia, what are your thoughts?
And my first thought was that the youth-driven approach, even though in this presentation we talked about it in like a systems level, policy level, that you can apply those same principles. And if you go to Youth Move National's website, we have a ton of resources on youth-driven, or reach out to me directly and I'll happily share some of our basic like primer packages on it. But what really comes to mind is that a youth-driven approach can be implemented in sort of a one-to-one relationship, particularly in a relationship where, like in a doctor's office or a clinical office, you really have kind of a one-directional relationship traditionally. Like one person certainly holds power where the other person doesn't, the younger person doesn't. And so these kinds of youth-driven techniques and approaches and sort of beliefs can really, again, change the culture of that organization, agency, or even that doctor's office. And for me, I think a lot of times if I have trouble engaging with a young person, I'm not good at Snapchat. I have a hard time with, Instagram and things like that. I'm learning, but it's slow. And, I'm in my 30s. So one thing I really try to focus on is asking a lot of questions. Like 3/4 of what comes out of my mouth should be questions. And then I really need to follow through. I think for young people who are systems weary, who have a lot of adults in their lives who maybe are not as attentive as that young person needs them to be, just following through and demonstrating that you are going to do as you say can really build a lot of trust with people in general, I think, but particularly young people who are kind of, looking to test us a little bit and see if we're trustworthy and see if we're going to be those supportive, reliable adults. So the follow through and just question led, being really open and curious, allowing space for those answers, wherever they may be.
And Elizabeth also pointed out motivational interviewing, which I think helps people with, all the things you were identifying, Lydia, and she agrees with you. Follow through is huge. Okay, so I'm going to advance us. Thank you both, Kristin and Lydia, and please follow up with any of us. I heard that there are things that can be done on an individual level, starting with knowing your own bias, moving into data level, what is really going on within your agency and in your community, and then to that policy level. Here I want to tell you about, if you haven't heard, that this is a great opportunity, leadership training for early career mental health professionals. Lydia will be a part of it in person. You don't have to just hear on the phone. It's in Phoenix, Arizona, and there's still slots available. I've been a part of the development of some of this leadership training, and it's really critical. It's really well done, and the young adults who are a part of your organizations would appreciate learning from Johanna and from Lydia. So
they're really fun in person too. It's way more fun.
They are.
They are fun. So please send them our way. Come our way.
And then I want to let you know that the session's been recorded and it's be available on the webpage within a few weeks. They take time to caption the sessions, which is a good thing to do for 508 compliance, and then it'll be available. If you want to learn more about the topics we've covered, reach out for additional resources. We'd love to hear from you on the website about things you would like to hear more about or would like support for. There's a needs query on the web page. And so that is, we talked about the importance of data. It's important data. And then your feedback for this season is very, very important. It's used by the funder. It's quick and easy to complete. You'll see it when we move on. And you will notice that the funder uses the term addiction, and for a variety of reasons that hasn't been able to be changed, but think mental health as you're completing it. Thank you to Lydia and to Kristin. Thank you for giving us a part of your day, and we look forward to having your feedback.
Thanks, everyone.
Thanks so much.